हेलो दोस्तों, कैसे हो आप? तो वेलकम बैक टू माय चैनल और हम आज डिस्कस करने तीन अमेजिंग सिनेरियो बेस्ड क्वेश्चन फ्रॉम रॉबिन्स रिव्यू एंड आई एम डॉक्टर रंजित. इफ यू आर हियर फॉर द फर्स्ट टाइम, सब्सक्राइब बटन दबा दो एंड लेट्स लर्न मेडिसिन एंड पैथोलॉजी टुगेदर. And if you've noticed, I've tried to learn a little bit of Hindi for conversing with you guys and to stay in touch with you for a longer time. So let me teach pathology to you and please put in the comment section any good learning resources for Hindi so that the learning becomes mutual. Chale, so let's discuss the first question here. So let's read the first question. It's a beautiful question. A 63-year-old man with a 2-year history of worsening congestive cardiac failure. Echo shows a mitral valve stenosis and left atrial dilatation. A mural thrombi is present. Mural thrombi. Mural means muscle, right? A mural thrombi is a thrombi attached to the heart. Because of the dilated left atrium, the virtual stride becomes normal. That's why you have a mural thrombi, right? It's present in the left atrium. 1 month later, he experiences left flank pain and notices hematuria. This is important. Could be a problem with that. The mural thrombi could have undergone embolus that could have stuck in the kidney because the loin pain and also hematuria, right? Okay. Labs finding shows a serum elevated AST. I don't know why it is there. Maybe a random finding. Representative microscopic appearance of the lesion is shown in the figure. Which of the following is the most likely pattern of tissue necrosis, which is likely to be present in this image, in this person, right? I'm not going to the image. The same way, images is not important in a scenario. Try to solve the scenario. Image is to confirm, that's all. Same way, image is to confirm the patient diagnosis in your OPD. Image is to confirm the diagnosis in a scenario-based question, right? So it's a clear-cut case of a patient with a heart failure with a mural thrombi undergoing embolus and getting stuck in the kidney. I know it's kidney because of loin pain and hematuria. The question is, what type of necrosis you will have in a renal infarct? Any solid organ infarct except brain has to be coagulated necrosis. That's all. Answer will be B only. Should be B only. It will not change. Now let's go and take a look at the image, right? We are different people. Undoubtedly, you'll be perfectly right. Look at this. Okay. Completely pink. Completely pink means it is definitely necrotic tissue. And if you look at this circle, that's my glomerulus. It's completely gone. If you look at this, I am 100% sure you will appreciate that these are my tubules. So this is where I want to introduce one more point to recollect from our notes. You must have definitely read that you will have ghost cells in case of coagulated necrosis. What do we mean with ghost cells or the architecture being maintained? This is a dead tissue. In spite of it being a dead tissue, the cells has the architecture, and you and me can still say it's a glomeruli. You and me can still say it's a tubule. That's what architecture being maintained, right? Or ghost cells. Ghost is something like this which does not have a life but has a shape. Scooby-Dooby-Doo, you remember that, right? The Casper, it has a shape but it does not have the life in it. Like that, a necrotic tissue has the shape retained of a tubule, has a shape retained of a glomerulus but does not have a life. That's your classical coagulated necrosis, right? So now obviously my answer is right. It's a coagulated necrosis in case of due to renal infarct due to a thrombus coming from the left atrium, right? Perfect. Let's go to the next question. Should be an easy guy this time. Okay, let's zoom it a little bit. Yep. Okay, let's discuss. Okay, start. A 54-year-old person experienced substernal chest pain for 3 hours. ECG showed consistent with a myocardial infarction. So it's a patient with a heart attack coming to the OPD. And after thrombolytic therapy with a tissue plasminogen activator, gave the thrombolytic therapy, his serum creatine kinase levels increased. Which of the following events must have happened in this patient after TPA therapy? So here, it's clearly mentioned that after the TPA therapy also, the creatine kinase is more, which means there's a little bit of more injury happening after TPA therapy. The reason is very simple. One of the reasons where I have more injury even after giving back the blood supply is reperfusion injury, right? So what is reperfusion injury? Reperfusion is a very, very simple concept. Let's say that I have a blood vessel. Let's look at a red color. Where did it go? Yep. I have a blood vessel which has been blocked by a thrombus. Fine. Reperfusion injury is nothing but it's going to remove this thrombus and it's going to give the perfusion again. So when I had a thrombus, by default, this tissue must have got a little bit of at least a reversible damage. If not a reversible damage or a dying tissue. That's how it is, right? And I'm salvaging it by giving new blood supply. So a dying tissue, when it's being given a new blood supply, by default, the new blood supply which is being introduced will have new reactive oxygen species. And this dying tissue will have very less antioxidants, right? So this new reactive oxygen species which enters the dying tissue is going to cause more injury. That's what we call as a reperfusion injury, right? Two questions here. Reperfusion injury is due to fresh reactive oxygen species induced damage. That's a question. Second, will it always happen? Answer is yes. Then how do I say? That's where your critical time of thrombolysis comes into play. If you give within the critical time of thrombolysis, the patient will have an amazing outcome. If you give after the critical time of thrombolysis, the damage is more and the benefit is less, right? That's the concept of reperfusion injury. Is due to reactive oxygen species induced damage in an already dying myocardium, or if it's a stroke in an already dying CNS tissue, right? Okay, perfect. Let's go to the next guy. I hope it will be easy. That's the last one for today. Let's discuss. Let's start. On the 28th day of a menstrual cycle, a 23-year-old woman experiences onset of menstrual bleeding. Fine, lasts for 6 days. Okay. Has a regular cycle since menarche. Which of the following process has most likely to occur in the endometrial cells to initiate the menstrual bleeding? So this is a useless question, right? So this has been a forced question to made into a scenario based. The question is simple. What happens, what cellular change must happen in a person's endometrium in order to it to be shed? That's all. Menstrual cycle, that's all, right? It's simple. If I have to lose a cell, physiologically, it has to be only one guy, which is apoptosis. It has to be apoptosis. It cannot be atrophy because it's not menopause. Menopause is different. Menstrual cycle is different. In case of menstrual cycle, which is a physiological death, by default, apoptosis is going to happen. That will shed all the endometrium, and the new endometrium will start proliferating again in the next cycle's proliferative phase, right? That's all for the 3 questions of today. If you have any doubts in the questions, in the points discussed, put in the comment section. And if you have any suggestions regarding Hindi also, put in the comment section. See you soon. Till then, bye-bye.